Good evening, everyone. I'm going to talk on the diagnosis, mainly the approach part and management part of hepatorenal syndrome today. A brief recapitulation of the previous session. That First, the pathophysiology in cirrhosis, there is architectural distortion and increased intrahepatic resistance, leading to increased portal pressure, causing portal hypertension, which leads to bacterial product translocation, which are called PAMs, pathogen-associated molecular patterns, and these, along with damage-associated molecular patterns, lead to inflammatory response, systemic inflammation, and together all of these cause release of certain vasodilators like nitric oxide, prostaglandin, and endocannabinoids, and thus it causes splanchnic vasodilatation. So on one hand, it causes splanchnic vasodilatation, and on the other hand, it causes renal vasoconstriction. Because of splanchnic vasodilatation, there is decreased effective arterial blood volume, which leads to activation of renin-angiotensin-aldosterone system and release of vasopressin. And that precipitates sodium retention, renal vasoconstriction, decreased renal blood flow, causing ascites as well as AKI. So the types of hepatorenal syndrome, in older times, it was coined as hepatorenal syndrome type 1 and 2. And now the new definitions have come, which are hepatorenal syndrome AKI type and hepatorenal syndrome non-AKI type. So the criteria for diagnosis of hepatorenal syndrome remains that there is no response after volume expansion with albumin 1 gram per kg per day for 48 hours. There is cirrhosis with ascites. There is absence of shock. There is no current or recent use of nephrotoxic drugs, diuretics, and NSAIDs. There is absence of parenchymal kidney disease. This is true for both HRS-AKI and HRS non-AKI. However, HRS-AKI, it involves increase in serum creatinine greater than 0.3 milligram per deciliter in 48 hours or greater or equal to 50% increase in 3 months. Whereas HRS non-AKI, it is classified into two classes. One is HRS-AKD, which is increase in serum creatinine less than 50% in 3 months, estimated GFR less than 60 milliliter per minute by 1.73 meters square, and there is no other cause of kidney disease, along with cirrhosis and ascites, presence of cirrhosis and ascites. And HRS-CKD is also the same, where the estimated GFR less than 60 milliliter per minute per 1.73 meters square. So then we come to the
Chandrima, can you just go back to that, because this is important for all of us. I would ask Rushiji or Das sir to give us a little more easier way to come to this, because it's really a little baffling. Or maybe you can give a little time for us to So can you please explain that what are the differences and why these differences had been done? What is the
Sir, previously.
Okay, Chandrima, you start, and then if they would join. Yep.
Sir, I will answer you, sir.
You can start. Please answer.
Okay, sir. So in HRS, previously the definition of HRS was HRS1 and HRS2. In HRS1, the definition was that there will be increase in serum creatinine greater than 2.5 milligram per deciliter. However, according to the previous definition, if we start treatment, it has been found that the treatment usually starts late, and the prognosis usually becomes even much poorer. So that is why the new definition has come, which is not increasing, which is not waiting for the serum creat to rise to 2.5 milligram per deciliter. They are just taking a baseline creat of around 3 months, they're just taking their baseline creat and noting the increase in serum creat greater than 0.3 milligram per deciliter, so that the treatment is initiated at the earliest phase.
Okay, and in the no AKI, there are two types you are saying, AKD and CKD.
Yes, sir.
So, and one
This is the new.
So why this no, and what is the difference between these two? I'm not.
What is the difference between the two of them, Chandrika?
I cannot find that difference actually.
What is the difference between the HRS AKD and the HRS CKD? That is a question for you.
Yes, sir. Even I was also looking at these two, but I also didn't find the difference between HRS AKD and HRS CKD that in
So it's only
the
the time. There's
in any
nothing
of
else
the
separating
text.
the two. Because by definition,
Okay.
CKD means something which is more than 3 months and not reversible.
3 months. Yes.
So there are two parts. Whenever you use the word CKD, we are saying that it is A, irreversible, and B,
Okay.
more than 3 months of duration. So you would not call something as CKD unless it is irreversible.
Okay.
Whereas whenever you have a AKD, you are kind of, you are trying to play on both sides. So you are saying that it may be reversible, but less likely. So the difference between AKI and AKD, the two, if you look at it now, it's basically trying to tell you that when you say AKI, you are more confident of the recovery for the hemodynamic injury. Whereas when you say AKD, you say that may not reverse.
Okay.
Okay. So those are by and large the main things that I take home. So what I look at now is, to me, the injury mechanism is not different between the three: HRS AKI, HRS AKD, and HRS CKD. The mechanism of injury remains the same. Everything that you mentioned regarding the mechanism of injury is the same. So why is it presenting differently? It is to A, duration of injury, B, severity of injury. So even if you have an hemodynamic injury which is potentially reversible, if you don't treat it in time, the injury itself can propagate itself to become chronic and irreversible. You understood that part?
Yes, sir. But then, sir, how to differentiate between HRS, CKD, and acute tubular necrosis? Because acute tubular necrosis is again becomes irreversible.
So ATN, right? ATN is not HRS
Yes,
itself.
sir.
I mean, the thing is that when you normally when you say ATN, you are trying to say that potentially curable or recoverable, right? So that was creating a lot of confusion. That is why these new terms. So pathologically, it's not going to look very different whether it is HRS, AKI, AKD, or CKD. So mechanism of injury is hemodynamically mediated. Irreversible injury in the kidney is always in the form of fibrosis. So more fibrosis, more permanent tubular injury, which is not recovering with time or medical treatment, is CKD.
Okay.
Whereas when you have, see, in all forms, you are going to get tubular injury, whether it is HRS, AKI, or AKD, or CKD. In AKI, the injury will show that the tubules are looking structurally normal, but not functioning normally. So there you give the treatment, terlipressin, albumin, whatever we do, and you see an improvement. In an AKD, the tubules are injured, but they're still viable. Whereas you say CKD and you are non-viability.
Okay.
So duration and irreversibility are the two criteria to call anything CKD. Okay?
Okay.
Sure.
Next we come to the history and examination. So history, in history, we have to note the following points. There should be presence of risk factors for cirrhosis, like in case of injection drug abuse or significant alcohol intake, presence of obesity and diabetes. There may be history of prior decompensation like jaundice, upper gastrointestinal bleed, hepatic encephalopathy, prior history of ascites. And along with that, in case there may be other causes of ascites as well, which should be ruled out, like in heart disease. There will be ascites, but along with that, there will be chest pain, orthopnea, syncope, and paroxysmal nocturnal dyspnea. In case of renal disease, there will be oliguria, uh, uh, and there will be hematuria as well. In case of pancreatic disease, there will be upper abdominal pain radiating to back along with ascites. So in case of malignancy, the patient will have significant weight loss and there will be history of some kind of lump or swelling. In case of uh, tuberculosis, there will be history of evening rise of temperature with night sweats and weight loss. So then we come to the physical examination. In case of physical examination, we'll find signs of liver cell failure, uh, like icterus, spider angiomas, pepper money skin, gynecomastia, splenomegaly, testicular atrophy. There will be loss of secondary sexual characters, caput medusae, carotid swelling, Palmar erythema purpura edema, and fetor hepaticus may be present in cases of hepatic encephalopathy. In ascites, there may be shifting dullness or fluid trill. Normally, shifting dullness is present when there is ascitic fluid more than 1.5 liters. Um, so there are four grades of ascites. Grade 1 ascites is usually very minimal ascites, which can be visualized only on ultrasound. Grade 2 ascites is moderate ascites where shifting dullness will be present. And grade 3 ascites is severe ascites or tense ascites where we will be able to elicit a fluid thrill as well. So in cases of heart failure or constrictive pericarditis, we'll get additional features like elevated jugular venous pressure, pulmonary edema, pericardial rub or pedal edema. If there is pancreatitis, there is Cullen sign, Gray Turner sign, and in case of malignancy, there will be lymphadenopathy, abdominal mass, or sarcopenia. So in this way, depending on the history and physical examination also, we can be able to identify various causes of different causes of ascites, and we can pinpoint whether the ascites is of hepatic type or some other system related. Next is diagnosis. So how do we diagnose from ascites? Usually, along with the other routine examination, routine investigations like complete blood count, LFT, RFT, we also do diagnostic paracentesis in all cases of ascites, especially the new onset grade 2 to 3 ascites. In patients with worsening ascites or any other major complication of cirrhosis, including acute or chronic liver failure, when there is clinical suspicion of HBP or there is a non-portal hypertensive cause of ascites. So when the patient presents with first episode of ascites, at that time the ascitic fluid should be tapped for total protein, albumin, serum ascitic albumin gradient, and neutrophil count. But in patients with recurrent ascites, neutrophil count should be done routinely, whereas other investigations should be restricted depending on the case. So, and 10 milliliter of the ascitic fluid which is tapped should be sent for blood culture also, so that those patients who are suspected to have spontaneous bacterial peritonitis, they can be identified early. So in ascites also, we look for serum ascites albumin gradient. So if the serum ascites albumin gradient is more than 1.1 gram per deciliter, it usually points towards portal hypertension. Whereas if the serum ascites albumin gradient is less than 1.1 gram per deciliter, it usually points towards, we usually have to look for ascitic fluid protein. So if the ascitic fluid protein is less than 2.5 gram per deciliter, then it points towards nephrotic syndrome. But if the ascitic fluid protein is more than 2.5 gram per deciliter, then we have to also send the ascitic fluid cytology, rule out presence of malignant cells, because if malignant cells are present, it points towards peritoneal carcinomatosis. However, when the malignant cells are absent, we have to look for ascitic fluid ADA to rule out tubercular peritonitis. So if the ascitic fluid ADA is less than 33, we should also do ascitic fluid amylase. And in ascitic fluid amylase, if it is greater than 1000, it is pancreatic ascites. If the ascitic fluid triglyceride is more, then it is chylous ascites. On the other hand, serum ascitic albumin gradient, if it is greater than 1.1 gram per deciliter, and ascitic fluid protein is less than 2.5 gram per deciliter, it usually points towards portal hypertensive pathology. And then the absolute neutrophil count, if it is greater than 250 with monomicrobial culture, it points towards spontaneous bacterial peritonitis. However, if the absolute neutrophil count is greater than 250 and the culture is sterile, it is culture negative nucleocytic ascites. And if the absolute neutrophil count is less than 250 with monomicrobial culture, it is monomicrobial non-nucleocytic bacteriocytes. And with absolute neutrophil count less than 250 and sterile culture, it is uncomplicated ascites. And if ascitic fluid protein is greater than 2.5 gram per deciliter and serum ascitic albumin gradient is more than 1.1 gram per deciliter, then we can send for serum BNP. And if the serum BNP is less than 182 picogram per milliliter, it is Budd-Chiari syndrome. If it is more, it points more towards heart failure. So the diagnostic criteria of AKI in cirrhosis is mainly if we try to define AKI in cirrhosis, this has come in the International Ascites Association of 2015 guidelines. So there is increase in serum creatinine by greater or equal to 0.3 milligram per deciliter in less than 48 hours, or there is 50% increase in serum creatinine from baseline. That usually defines AKI in cirrhosis. Now, this AKI in cirrhosis is divided into 3 stages. One is stage 1, which is increase in serum creatinine greater than 0.3 milligram per deciliter in less than 48 hours, or there is increase in serum creat greater or equal to 1.5 to 2 times from baseline. Whereas stage 2 is increase in serum creat greater than 2 to 3 times from baseline, and stage 3 is increase in serum creat greater than 3 times from baseline, or serum creat is greater than 4 gram per deciliter with an acute increase of greater than 0.3 milligram per deciliter, or there is initiation of renal replacement therapy. So how do we approach when there is AKI in cirrhosis? So if there is stage 1A, that is the serum creatinine is there is increase in serum creatinine by greater than 0.3 milligram per deciliter in less than 48 hours, or serum creatinine is less than 1.5 gram per deciliter, that is stage 1A. In that case, first we stop all nephrotoxic drugs, diuretics, beta blockers, AC inhibitors, and angiotensin receptor blockers. We try to look for infection. We try to assess the volume status of the patient. This we can do by 2D echo screening of the patient to assess the ejection fraction and to find out whether the patient can tolerate fluids or not. We can also look for the inferior vena cava collapsibility index. If the inferior vena cava is collapsible and it provides a window for us to give fluid, volume expansion, then we can try with 1 gram per kg albumin for 2 days. This is true for stage 1B or higher stages, that is for those with serum creatinine greater than 1.5 gram per deciliter. In those patients, if we give a volume expansion with 1 gram per kg albumin for 2 days and look for the response, if the patient is fluid responsive, then that is mainly pre-renal, and we generally follow up those patients to see whether it resolves with fluid resuscitation or not. But if there is no response with volume expansion with 1 gram per kg albumin, then we have to look for other criteria of HRS-AKI, and we have to individualize management depending on that. So if the HRS-AKI criteria are met, then we have to start albumin along with vasoconstrictors. But however, each patient is a different patient, and we have to individualize treatment according to the clinical features of each patient, because if a patient presents with increased lactate along with the HRS-AKI symptoms, then we cannot wait for volume expansion and all, and we have to start early initiation of dialysis as well. So there are certain differences between HRS and ATN. So in HRS, there is no evidence of recent shock, but in ATN, there is usually evidence of recent shock like ischemia, or there may be presence of certain nephrotoxic drugs leading to these kind of causes, leading to tubular necrosis. Response to volume change is not present in case of both HRS and ATN. However, in case of HRS, the urine sodium is less than 20, but in case of ATN, it is greater than 40. If we consider the fractional excretion of sodium, it is less than 1 in HRS, but it is greater than 1 in ATN. Urine osmolarity is less than 500 in HRS, whereas it is greater than 350 in ATN. And in acute tubular necrosis, we will find presence of granular cast, which we will not find in hepatorenal syndrome. And nowadays, many promising urinary biomarkers have come into the market, like NGAL, interleukin 18, KIM1, and albumin. NGAL is out of them is a marker of renal injury, and it helps in distinguishing between HRS and ATN. More specifically, the cutoff with the best predictive accuracy for ATN diagnosis was found to be 220 microgram per gram of creatinine in case of NGAL. However, the disadvantage is it is not universally available, and so it cannot be applied on a broader basis. Now, the treatment or management of HRS, it includes general measures, pharmacological treatment. We can also look for surgery, like we can use combination therapy of pharmacologic treatment, renal replacement therapy, therapeutic plasma exchange, and definitely the definitive treatment of hepatorenal syndrome remains liver transplantation. So general measures, patients with type 1 hepatorenal syndrome, they usually require hospitalization because they usually have poor prognosis and lesser time for survival. Whereas those with type 2 hepatorenal syndrome, they can be treated on an OPD basis. In hospitalized patients, as I have already discussed, that fluid administration has to be carefully monitored, because if we administer less amount of fluid, it will be it may cause hypotension, but if we give more fluid, it may precipitate fluid overload in these patients as well. Diuretics, nephrotoxic drugs should be stopped. We should also exclude other causes of acute renal failure and look for precipitating factors like spontaneous bacterial peritonitis. And in case of spontaneous bacterial peritonitis and gastrointestinal bleeding, we should start some antibiotics like third generation cephalosporin to provide a cover. Special consideration should also be given to the nutrition of these patients because these patients are usually depleted. They are usually malnourished. But we have to also see that we do not provide a very high protein diet to these patients because high protein diet may again precipitate hepatic encephalopathy and aggravate the metabolic abnormalities. A low salt diet should be reinforced in all cases, as well as free water restriction in those patients who develop hyponatremia. Next is albumin. Among the pharmacological therapies, albumin has been...
Just one thing here. So
Yes,
just important thing which I want to talk about here is, protein restriction. So there is
yes,
absolutely no role whatsoever of restricting the proteins. In fact, you should be liberal. The recommended protein intake, even in the presence of cirrhosis and HRS, is 1.2 to 1.5 grams per kg body weight of proteins. And the only thing is that it should not be aromatic amino acids. We should have more of branch chain amino acids. So as long as it is
okay,
branch chain amino acids and not aromatic amino acids, it's absolutely fine. So we should not restrict. Even in the presence of hepatic encephalopathy now, up to grade 1 to 2, there is no role of restriction of proteins. So we should not attempt to do that. It is detrimental. It affects the outcomes actually adversely. So protein restriction is now associated with worse outcomes.
okay. Okay. So one of the treatment which we use for hepatorenal syndrome is albumin. So albumin, it maintains the colloid osmotic pressure, thereby maintaining intravascular volume. It has antioxidant, immune modulating, and endothelial stabilizing properties, helps in clearing reactive oxygen species, cytokines, and various bacterial products. And these antioxidant and anti-inflammatory properties of albumin also have some beneficial effects on increasing the cardiac output in patients with cirrhotic cardiomyopathy. So the indications of albumin in liver disease, we usually use albumin in liver disease in large volume paracentesis, spontaneous bacterial peritonitis, HRS, AKI, and refractory ascites. So in case of large volume paracentesis, albumin is usually given to prevent post-paracentesis circulatory dispersion. Here we usually give albumin 8 gram per liter of ascitic fluid tap. In case of spontaneous peritonitis, bacterial peritonitis, we give albumin in the dose of 1.5 gram per kg on day 1 and 1 gram per kg on day 3. In case of HRS AKI, we give albumin in the dose of 1 gram per kg per day. Maximum dose which can be given is 100 grams per day. However, in most of the routine practices, what we give is 20 to 40 grams per day of albumin. In case of refractory ascites, also albumin has been found to have a role. If we give 20 grams twice a week, it has been found that it improves outcomes in patients with refractory ascites. However, it has been found in certain trials like a TIRE trial, which is albumin to prevent infection in chronic liver failure, that there is no role of albumin when there is sepsis in liver failure. It has not been seen to reduce any 3-month mortality or complication. There is no role in acute or chronic liver failure. And on the other hand, albumin, if it is given in patients who have a lower threshold for volume expansion, it can also lead to fluid overload or precipitate myocardial. It can also precipitate pulmonary edema. Sir, is there any other contraindication of albumin?
So yes, Actually, what I have very importantly told us that, what are the indications? So there are actually very limited indications of albumin. If you can just go back to the previous slide. So I think this is a very, very important slide that, it is not indicated in all the infections that a cirrhosis patient has. It is basically restricted to, sorry, I can't see the slide. Sorry, can you hear me now?
Yes, sir. I can
Yeah.
hear
Can you hear me?
Yeah. Very good.
Yes, sir.
Yeah. So I think this is a very, very important slide because the indications of albumin in liver disease are actually very limited. So it is one of the most abused drugs in cirrhosis. The indications, as very rarely when there are large volume paracentesis. Basically, the initial trial had shown that they had used this dose, but subsequent trials have shown that even around 40 grams of albumin per day for the first 3 days is actually adequate. So you don't have to really give 1.5 grams or 1 gram per kg because that becomes most of our patients do not tolerate. So even in the West, many of them will now use only 40 grams and not as high as what was reported in this trial.
Okay, sir. Okay.
Sir, I have one question, Shukla sir. What is the maximal possible dose for albumin in a day? It's normally given 40 to 50.
100 grams.
100 grams is the maximum possible. So
100 grams is the maximum which has been given. But if you look at the subsequent studies, they have shown that 40 grams per day for 3 days is as good as giving 1.5 gram per kg or 1 gram per kg. So now we are more comfortable giving 40 than giving 1.5 grams per kg or 100 grams more that dose.
I think this is a good exam question for the our fellows. So remember this, the contraindications, proper indications, as well as standard dose, maximum possible dose, and which dose has have a proven benefit. Chandrima, kindly continue.
Yes. Next is systemic vasoconstrictors. Now, they are the most promising pharmacological agents in the management of hepatorenal syndrome. Out of this, terlipressin holds the first place, followed by octreotide and midodrine and norepinephrine. So, terlipressin, it is nowadays considered as the first-line treatment for hepatorenal syndrome. It is a vasopressin analog. It induces vasoconstriction by acting through V1 receptor of the vascular smooth muscle cells. In that way, it decreases portal pressure and also it decreases the intrahepatic resistance, leading to subsequent redistribution of blood volume to the systemic circulation, causing an increase in mean arterial pressure and thus improves renal perfusion as well. So it has been found that if we administer terlipressin and albumin together, it has caused significant improvement in GFR. It has led to increase in arterial pressure, near normalization of neurohumoral levels, and there is also reduction of serum creatinine in 42 to 77% of cases. However, terlipressin has a few side effects, like it can cause cardiovascular side effects like arrhythmia, angina. It can lead to abdominal ischemia and thus may cause abdominal pain and diarrhea. In some patients with grade 3 acute on chronic liver failure, terlipressin has been found to cause respiratory failure. It may also cause skin necrosis. Therefore, in patients with ischemic heart disease and peripheral vascular disease, terlipressin should be used very cautiously. The dosage of terlipressin, we can give intermittent boluses at an initial dose of 1 milligram every 4 to 6 hours, increasing to 2 milligrams every 4 to 6 hours. maximum daily dose of terlipressin which can be given is 12 milligrams if there was less than 30% reduction in the serum creatinine by day 4 of treatment after at least 10 doses. So the treatment can be continued for up to 14 days or stopped earlier if if the patient has a reversal of hepatorenal syndrome. Treatment could also be stopped on day 4 for non-response if it is found that the serum creatinine is continuing to rise despite treatment.
So I think here you are actually looking into resolution of the level of creatinine, right? 25 to 30% decrement on day 4.
Yes.
That's what dictates that.
Yes.
That's the therapeutic goal, rather we could say, which decides whether we should continue or we should think of something else. Very quick question to our learned hepatologist, sir, and anyone else who can answer. Is there any difference, sir, between intermittent or a continuous infusion?
So the continuous, yeah, so excellent question, Arindam. So the continuous infusion is much better tolerated than intermittent dosages. The side effect profile is much better. The efficacy is the same, whether you give continuous infusion or the intermittent dosages.
Okay, so in terms of tolerance, I think practically we should give continuous infusion.
Yeah.
So here there was a study performed by Carvalin et al. It was a multi-center study and it actually compared bolus doses of terlipressin with continuous infusion of terlipressin. And what they found that continuous infusion was able to achieve the same response.
Exactly what sir said, that non-inferior study, yes, comparative but with a much lesser side effects. Yes. Okay.
Yes.
Thank you.
Yes. Next, we can also use noradrenaline. Noradrenaline activates the alpha-1 adrenergic receptor in the vascular smooth muscle cells. It causes increased peripheral vascular resistance in advanced cirrhosis and thus helping improving the mean arterial pressure and renal perfusion pressure. It is usually started at a dose of 3 milligrams per hour with a target to increase the mean arterial pressure by 10 millimeter mercury or increase in urine output by greater than 200 milliliter in 4 hours. However, noradrenaline, if the dose of noradrenaline goes up to too much, then the patient will require a central line and those patients need to be monitored in ICU. The next combination which has been tried in the treatment of hepatorenal syndrome is octreotide and midodrine. Octreotide is an inhibitor of glucagon and other vasodilator peptide release, and midodrine is an alpha adrenergic agonist. Individually, they have not been found to play any significant role in hepatorenal syndrome. However, when both of them have been combined, they have slightly improved systemic hemodynamics, but they failed to improve renal function in 8 patients with type 2 hepatorenal syndrome in a study. However, when both of these agents are given in combination with albumin, it has been found that there is a significant improvement in renal function and survival in a study where 5 patients actually benefited with the combination therapy of octreotide, midodrine, and albumin. When medical management fails, then we can also go for transtubular intrahepatic
Chandrima, I have a practical question, Akash sir. That if I am getting a good result with albumin and terlipressin, then why would I go to midodrine octreotide combination? Can it be used as a salvage therapy, or this is for a continuation of therapy with midodrine, as it can be given as an oral format?
Yeah, so you're absolutely right, Dr. Arindam, that albumin terlipressin, when it works, you cannot discharge the patient on this therapy. Whereas midodrine octreotide is something which the patient can be given at home also. So once somebody is dependent on terlipressin, while you're doing tips or while you're doing transplant for this patient, you have to bridge the patient. So if you can send the patient home and the patient can maintain on octreotide midodrine, then that becomes very useful. Otherwise, you have to keep the patient in the hospital and give terlipressin and albumin till you can do tips or transplant. Also, I would want to just add a few theoretical things about albumin, which I think will be very important for the residents, for them to understand why we say that albumin can actually be harmful. So, for some basic facts about albumin, remember that albumin is basically manufactured exclusively in the liver. There is no other place where albumin is manufactured. And once it is synthesized in the liver, it goes into the systemic circulation within 30 minutes of it being produced by the hepatocytes. Unfortunately, all of it doesn't remain in the intravascular compartment. Whatever comes in the blood, almost 40% only will stay in the intravascular compartment. 60% of this will actually escape into the extravascular space. And that is why sometimes you'll find that some patients will feel worse after you have given albumin to them, because they actually increase their edema once you give albumin. So it is not that in everybody, once you give albumin, the edema will come down. This movement between the intravascular space and the extravascular space is basically called as transcapillary escape, and the rate at which this happens is called as transcapillary escape rate. And the leak from the intravascular to the extravascular compartment on an average is around 5% per hour normally. Unfortunately, what happens is in patients with cirrhosis, because of the leaky capillaries and the high portal pressure, this leakage rate actually doubles. So even if you give albumin to the patient, it is very rapidly escaping out of the intravascular compartment and going to the third space. And that is what is sometimes causing trouble, because then it pulls with it water flux, causing pedal edema and ascites. And if one of the future targets to prevent this leakage is something called as albondin, which is a GP60 receptor, which is present in the vascular bed, which is responsible for transporting the albumin to the interstitial side. That is the third tissue, the third space. Also, in patients with liver diseases, this albumin is actually modified and exists in three major forms. One form is called as the uh, uh, the human mercapt albumin. Then there is something called as non-mercapt albumin 1, and then there is something called as non-mercapt albumin 2. So what happens is, because of the oxidative stress and presence of all these reactive oxygen species in the serum, very often the albumin which we give or which the body is producing becomes oxidized. And once it is oxidized, it becomes, actually the structure becomes altered. It is no longer able to act as a scavenger for all the DAMPs and PAMPs. It is unable to cause drug delivery to the peripheral tissues. And this is actually called as ischemia modified albumin, which is circulating. And presence of ischemia modified albumin in patients with liver diseases is actually associated with worse outcomes. So if a patient has infection, if the patient has severe oxidative stress for whatever reason, so for example, patient in SIRS, and if you give this patient albumin, it will actually get hyperoxidized. It will become what is called as IMA, ischemia modified albumin, and will actually have more detrimental side effects to the patient. And therefore, for us in nephrology, I think for you all, it will be very important that when you do plasma exchanges for patients who have liver disease, where there's very high oxidative stress, you would not want to replace the plasma with albumin. Sometimes you do half plasma, half albumin. So those sort of things. So you would not want to do it if the patient is having high levels of oxidative stress. If there's severe SIRS, you expect high levels of TNF alpha in the blood or interleukin 6. So I think those are the, if you think the translational aspect of the basic science is something which I think as a resident you all should know.
Yes, sir.
We learned about the IMA. We always thought the IMA is something else, but definitely, I would definitely read more about it. And this is what we really want to learn from you, sir, that what is the translational, how we can actually convert bench to bedside, which is a huge gap, because a lot of times the basic researchers are more focused into the research, and the clinicians are little. So there are very few people like you who actually can bring the best of the basic research into more functional way to the day. Chandrima, please continue so that we can listen more from Shukla sir.
Yes, sir. So next is when medical management fails, so we can also resort to surgical management, which is transtubular intrahepatic photosystemic shunt. So here, an insertion of an intrahepatic stent is done to connect the portal vein to the hepatic vein. This shunt actually redirects portal blood into the systemic circulation and thus reduces portal pressure, increases the systemic venous return. And in this way, it reduces the arterial hypoperfusion and downregulates the stimulation of renin-angiotensin aldosterone system. However, the procedure itself can lead to hepatic encephalopathy. So this was a study performed by Guevara, in which they have found that after TIPS insertion, the biochemical, hemodynamic, and neurohumoral profile of 7 patients with type 1 hepatorenal syndrome improved, and there was significant reduction in serum creatinine and increase in urine volume. In case of acute liver failure, in those patients who are not opting for liver transplant, therapeutic plasma exchange has also been tried, and it has been found that they allow recovery of native liver function by facilitating liver regeneration by reducing the inflammatory mediators and removal of toxic substances. So renal replacement therapy. When to initiate renal replacement therapy is very controversial in untreated patients who have type 1 hepatorenal syndrome, because the chance of survival and morbidity mortality rates associated with type 1 hepatorenal syndrome are usually poor, and the prognosis is also poor if they are not candidates for liver transplantation. So the decision to initiate renal replacement therapy in these patients should be individualized. And renal replacement therapy usually we do in those patients who are unresponsive to pharmacologic therapy, who have volume overload, electrolyte derangements, and also have symptoms of uremia. So in those patients, usually continuous renal replacement therapy is preferred over intermittent renal replacement therapy, because hemodynamic stability and electrolyte balance is more maintained in case of continuous renal replacement therapy compared to other modalities. And so because if we do intermittent renal replacement therapy, there may be more chances of hypotension and cerebral edema. Liver transplantation, this is actually the definitive treatment of hepatorenal syndrome AKI, as this corrects the underlying portal hypertension and liver dysfunction as well. So therefore, whenever patients with hepatorenal syndrome AKI patients come to our ICU, they should be referred for liver transplant assessment also as soon as possible. Once accepted onto the liver transplant waiting list, they are prioritized according to the serum creat and also the MELD score. And some important things which have been found is that if there is response to vasoconstrictors, if there is good response to vasoconstrictors before liver transplant, it has been shown to it has been shown that there is improved survival post-transplant as well. If there is treatment with vasoconstrictor therapy before transplant, there is less chances of post-transplant renal replacement therapy requirement. And in patients who required renal replacement therapy before transplant, liver transplant should not be delayed because the most important predictor of post-transplant renal function recovery is the duration of renal replacement therapy before transplant. There is another thing which has recently come into practice is simultaneous liver kidney transplant. So lots of controversy have been there for simultaneous liver kidney transplant because it actually takes away an organ from patient on the kidney. It takes away one patient from the kidney transplant waiting list. It is considered usually for those patients with HRS-AKI who are unlikely to have renal recovery with liver transplant alone in patients with underlying CKD or hereditary renal condition. There are some selection criteria for both lung and kidney transplant. In that, there should be sustained AKI. The patient should be having AKI for more than 6 consecutive weeks with either estimated GFR or creatinine clearance falling below 25 milliliter per minute and patient requiring regular dialysis. If there is a CKD with estimated GFR less than 60 milliliter per minute for more than 90 days, with a patient having end-stage renal disease on dialysis in a hospital-based, independent, non-hospital-based or home-based setting. If there is inherited metabolic disorders like hyperoxaluria, if there is atypical hemolytic uremic syndrome, there is methylmalonic aciduria or familial mononeuropathic systemic amyloid. If any patient is registered on the kidney waitlist between 60 and 365 days after transplantation and is either on chronic hemodialysis or has an estimated GFR less than 20 milliliter per minute, that patient will qualify for increased priority after liver transplantation alone. Or if there is any solitary lung kidney transplant recipient who has experienced immediate and permanent non-function of the transplanted kidney. So can you throw more light on this?
I think Shukla sir has left, so I will ask Rushi sir or Das sir to comment on this. Little bit of. Yes, sir, you are audible.
Yeah. So basically, this criteria for selection for transplant depends on the organ procuring agency. So in our city, it will be the ZTCC. So these are not uniform across the country or across the world. Okay. So that's one thing to understand. Second, like I said before, for us here, normally patients who have simultaneous need for liver and kidney transplant, we would register them for what we call as SLKT or simultaneous liver and kidney transplant. Now, either you can do a simultaneous liver and kidney transplant if you have two related donors for the same patient, one donating the liver and one donating the kidney, or you can list them for a deceased donor program, where whenever there is a donor who can, they can be, getting the organs from the donor, liver and kidney. Now, in our OPO, organ procurement organization, the kidney follows the liver. So the main organ is the liver. So whoever gets the liver will automatically get the kidney irrespective of the waiting list for the kidney. These are all technical things as far as the wait list is concerned. From a scientific point of view, it is better to get liver and kidney from the same donor always, because the antigen load is so high that the chances of rejection would be very small if the person is getting liver and kidney from the same donor. So that is one big advantage. We can get the organs from the same donor. In terms of listing for the kidney transplant in a patient who is listed for liver, we need to establish primarily the irreversibility of the disease and the severity of the disease. So by reversibility, we mean time, duration of the disease, and by reversibility, we mean no improvement in GFR after a therapeutic trial with albumin terlipressin. So if your GFR is less than 20, and we need to prove that with the perfusion scan or something, because these are reports which will be required for listing for simultaneous transplantations. What happens, if you have a like what we said, HRS NAKI, right? So if you have a HRS NAKI and you go ahead only with a liver transplant, the outcomes post-transplant are very poor because the need for renal replacement therapy, dialysis, post-transplantation will not just affect the renal part definitely, but it will make even the outcomes of the liver transplant worse. So that is why it is preferred that these patients go for simultaneous liver and kidney transplant and not liver transplant alone. Okay.
For our fellows and DNB students, don't be happy with HRS NAKI. NAKI means there is no AKI, but rather there is either an AKD, which is, I think, the line of demarcation is 90 days, less than 90 days, or which AKD, or a CKD, which is the renal dysfunction more than 90 days itself. So NAKI means there is no AKI, but rather there is a CKD component into it. So most of them will require a simultaneous liver kidney. I think Mihir, are you there? Can I ask you a couple of questions?
Yes, sir.
Okay. So Chandrima, can you go back to the this one tips? A little idea on that. Which sort of patient do you select for tips? What are how does it help? And which are the patients who doesn't qualify for tips or should not get a tips? And what are the circumstances you have to think of reversal of the tips itself?
So, sir, when we do tips, the first goal is that do no more harm. So sometimes you want to plan tips in a person, MELD score close to 18 and below. We want to ensure that they have not got bad hepatic encephalopathy. Size of the liver plays a very big role. Small shrunken liver sometimes may not do good post tips because they then develop liver failure because of aggressive shunting. And sir, sometimes when you're planning tips, you may even go ahead by having a living donor ready, that in case post tips, if people develop decompensation, our living donor is ready and you can expedite the early liver transplant. Hello?
Am
I audible, sir?
Yes, you are audible. That's quite interesting.
Sir, we will plan in such a way that you have tried to cover maximum complications. Second, while planning a tip, sir, we sometimes would do dobutamine stress echo and sometimes even try to see the right side of the heart. If DSC cannot be planned, you even have done stress thallium prior to doing a procedure, because suddenly, because of a stiff, hard liver, there is so much resistance that the blood flow to the heart was very low. After putting in tips, there is so much shunting that all the blood will suddenly come into the right side of the heart. That time we don't want heart failure to come into picture.
So you want to actually know that whether your right heart is ready to accept that amount of blood.
Yes, sir. Prior to tips, that is a good thing. So there are absolute contraindications and relative contraindications. In absolute contraindication is grade 3, grade 4 HE, very high MELD score. The cutoff is 18. And there you take into account size of the liver and other etiological assessments. So bad ACLF with multi-organ failure or having more than 2 to 3 organ failures. TIPS is not an answer.
Obviously, I think active infection is also one of the
yes, sir. Yes, sir. Yeah, because you don't want tipsitis to come into picture.
Yes, yeah.
And there, in relative contraindication, age becomes a number. And when you are trying to see the MELD score at that point of time, as part of your relative contraindication. So second, sir, you said about that if you have done a tips, you would want to keep around 6 to 8 millimeters dilatation. Sometimes too much of dilatation, around 8 to 10 millimeters, may shunt too much blood away from the liver and precipitate hepatic encephalopathy. So that is a time you may then try to reduce the diameter of the tip stent by placing in one more stent through the tips. That will help you to reduce the
stent inside.
Stent in stent,
yeah.
Stent in stent, so that you reduce the diameter of the thing. And at the same time, there are certain people with type 2 HRS. This is becoming a more bigger indication now, where we are doing tips, where we accept that there is some early CKD or type 2 HRS where creatinine is 1.4, 1.5. They are developing refractory ascites, and we are requiring to tap a lot. So this cohort, as a bridge to transplant, we can think of doing tips.
How it would help?
Because, sir, they are on the cadaver waiting list. They don't have a living donor available. Maybe buy some time so that the repeated complications of tapping, as well as requirement
it would
of
help in the term. It would help in terms of reducing the ascites. No way it is going to help the renal function in any way.
So type 2 HRS, sir, where this could be one of the indications. In people, sir, pleural tapping, like repeated pleural tapping, which is very difficult to plan. So few cases, sir, there we have planned tips as part of hepatic hydrothorax.
And in what circumstances do you think of reversal of tips?
When there is, after putting in tips, there is bad grade 3, grade 4 hepatic encephalopathy, not getting corrected through standard measurements. So it becomes a refractory HE. So you would want to then reverse the tips. Very rarely you have to do it. But sir, yes, in one case we remember, sir, we had to plan this.
Fair enough. Okay. Chandrima, the next slide, just look into after one slide after tips. I was wondering on that. No, not that. Next one. Yep. Plasma exchange. Any comment on this as one?
Sir, plasma exchange, this is acute liver failure, sir. Means not relevant to a topic of HRS, but just commenting on that. Acute liver failure, if it is Renal poisoning, definite indication of doing plasma exchange. 3 to 5 sessions and demonstrated standard good clinical benefit. People who are on CRRT and demonstrating a cytokine storm and developing features of raised ICT in acute liver failure, there is a standard indication.
This topic we will cover in a separate. I think we would require more than one class.
That is the reason, sir. HRS, no, sir. No role, sir. No role, sir.
Okay, fair enough. So very clearly, no
role. ACLF, sir, yes, but not in ALF, sir.
Okay. Next one. Next day and RRT to comment.
Summary, yeah. Excellent summary.
Okay. I think Rushi sir, any closing comments?
I think the topic was well covered today. So I think the only thing we have left to discuss now is plasma exchange and RRT. These are two topics which are remaining in terms in association with the same topic. I think plasma will take significant time. RRT that way is straightforward. So let's keep that for the next session.
Should we keep the topic that RRT and plasma exchange in liver patients or something? So it becomes broad and we can cover most of the things.
So you could keep plasma exchange, adsorptive filters, and RRT in the next session.
So we'll put it there. So I will again invite Shukla sir and Mihir, Amit, Mridul, all of you, and or your entire liver team. So that we want you to have association with us regularly so that we can learn from you guys. And so next week, we will come back with more on RRT, plasma exchange, and filters, different filters that can be used in on a chronic liver or an acute ACLF or acute or chronic, and also how a combination of critical hepatology, critical nephrology, and proper ICU, general ICU people can interact and come up with the best outcome for the patient. Hina, not only clap, you need to ask questions. Fair enough. Okay, so guys, please, I request you to ask questions, because if you ask all questions, then only your quest or quench for your knowledge would be satisfied. And thanks, Chandrima, for giving good A. Yes, Sheetal, endpoints of therapy and futility. We will discuss today. We have exceeded the time, and we'll come back and discuss on that endpoints of therapy and where you can actually have to consider futility. We'll come to that.
अरिंदम भाई,
हाँ
हाय।
सर, सर आप
आई
कब
थिंक
आए? I haven't
मैं
seen you.
मैं 1 घंटे से लॉग्ड इन हूँ, सुन रहा हूँ सब कुछ। मैं
ओ
मेरे
अच्छा
दो मेरे मेरे 2 टॉक्स बनाते बैठा था, तो मेरा भी काम हो रहा था।
अच्छा,
I think
sorry, I
Chandrima
didn't.
did a much better presentation today and really well done. And I think topics for next week are also very good. It would be interesting to have everybody again for the next week.
Fair enough, sir.
Yeah.
Sorry, I didn't see you.
No
So,
problem.
Thank you, sir.
thank you. So,
Good.
thanks, Chandrima. Thanks, Rushi, sir, Pandit ji, and also Das, sir. And obviously, Shukla, sir, has given us the most of the A. So, next class will be on the same date, Thursday, next Thursday, 7 o'clock. And we'll give you the presenter and A by tomorrow. Thank you,
Yeah.
and good night, all.
Good night. Bye-bye.
Pandit ji, I have sent you the SNCC format.
I liked it. Quite good.
Okay, thank you. Thank you.